So we have a nice group today. A nice group of primarily young orthodontists from Russia. And first of all, I'd like to introduce you to our first guest today, Dr. Charles Greene, and he graduated from University of Illinois, and for many years he has been involved in clinical research, and he was teaching in the area of TMD and orofacial pain. From 1986 to 1995, he was co-director at Northwestern University Dental School's TMD clinic. He was a clinical professor in the Department of Orthodontics at UIC until he retired in 2018. I personally have been admiring articles of Dr. Greene for a long time, and I consider all of his writings to be very eloquently put, and I've been learning a lot over the years from the work of Dr. Greene. So that's my introduction. And Dr. Greene, the stage is yours.
Okay, well, thank you very much. I want to thank Alex for inviting me to join you here today. One of my greatest pleasures in my academic career has been working with orthodontists, although I want everybody in the room to know I'm not an orthodontist myself. I'm a general dentist. I practiced general dentistry throughout my entire academic career for the first 35 years until 2001. Then I finally retired to the full-time academics. So I have a good knowledge of general dentistry. I didn't have a very good knowledge of orthodontics. And when I was teaching originally, I was teaching mostly to oral surgeons and general dentists in school, and the orthodontics was a department down the hall, and I didn't have anything much to do with them. And one day, Dr. Cyril Sadowski, a famous orthodontist in the department, came to me and he said, "Could my residents please rotate with you and spend some time in your clinic?" I said, "Well, that sounds like a nice idea. Let's plan some seminars to get to know each other and find out what everybody knows and wants to know and needs to know." And my first assignment was to say to them, "Listen, I have not read the orthodontic literature on TMJ. I've read the prosthodontic literature. I've read the occlusion literature. I've been working with all the studies that I do, but I never really crossed over into orthodontics. So your first assignment is to go out and read the orthodontic literature on TMJ and come back and report to me." And so they began to do that. And that's when I began to first understand how, shall we say, complicated the orthodontic world was. Because the orthodontic world was divided up into tribes or groups or cults or subgroups or whatever you would like to call them, clubs. And they were following different leaders and they had different ideas. But the most amazing part was that everything they wrote about TMJ somehow could be taken care of by orthodontists. And I never knew that before because I always thought it was being taken care of by prosthodontists grinding on your teeth and repositioning your jaws, which was, of course, horrible. And so I was disappointed to find out that the orthodontists had their own version of doing it. They just didn't grind away your enamel. So I began to realize I had an interesting challenge ahead of me. And I got to understand the orthodontic literature more over the years. And just by luck, I spent some time at Northwestern, as Alex said, with Dr. Harold Perry for 10 years there in orthodontics department, and then another many years, 15 or more years at Illinois in the orthodontic department as the TMJ guy in the department. So I think I have a good feeling for what orthodontists need to know and should know. So my purpose today is to convince you that you need to know at least 6 different things about the TMJ and about TMDs, no matter how you feel about it. So even if some of you in the room are really mostly interested in other things and don't really like TMD very much, and you would prefer to refer the patients away or never see them, never take care of anybody, that's not good, because it turns out you cannot avoid it. It's in your career path, no matter how you feel about it. So because it's in your career path, you have to be ready to deal with it. So my purpose today is to persuade you of that. And I will try to do that in first half of my lecture. And the second half, I'll be showing you a remarkable case that was done in Japan, which was very, very questionable, shall we say, arrogant approach of a Japanese orthodontist to treating a TMJ patient for 5 years. So I'm going to share my screen with you now. In writing this paper, I realized that it was time for me to make a statement that the orthodontic community needs to be involved, but they need to be involved appropriately and not inappropriately. And what I learned from the early orthodontic students who visited me at Illinois when I was first teaching is that orthodontists were either claiming to be curing or causing TMJ problems, which was contradictory. And we'll talk about that in a minute. So I realized that there are some important reasons that you have to be involved, but we don't want you to be the treaters of TMD. So if there never was anything in the world such as an orthodontist, the TMD community would be okay. We could live without orthodontists. We don't need orthodontists to join the TMD community if they didn't exist. But you do exist, and you do have something to offer. The trick is for you to offer the right thing and not to offer the wrong thing. So I start out with this quotation from my friend Jeff Okeson, who said, why should orthodontists care? And he says, it's difficult to imagine a specialty that routinely changes patients' occlusal condition and not having a powerful effect on the structures, including the TMJ. But of course, that's true, but what does it mean when you translate it? So I go back to a paper I wrote earlier. This is from 1988 in the Dental Clinics of North America. And I wrote, does orthodontic treatment cause, cure, or prevent? And you'll notice I have an asterisk next to all three. So I'm going to start out by answering that the answer to the question is no, no, and no. But actually, it's not completely true. As far as prevent goes, we have absolutely no evidence at all. And in fact, we have contradictory evidence to say that you prevent TMD. So that any claim by the orthodontic community that their treatment prevents TMDs has already been settled by a tremendous body of research. You really don't have to waste your time going through that. The incidence of TMD in the community is the same in untreated patients as it is in treated patients when it comes to orthodontics. That means you have no effect on that. Now, can you cause it? Usually not, but it's not impossible. There's two ways you can cause it. One is by being a bad orthodontist and doing a really bad job so that you overstrain the system and the system can't adapt to what you do. And the other way is by having the bad luck to have a susceptible patient who, even though you're doing ordinary mechanics, they begin to respond with some negative symptoms. And you have to recognize that. So you're the proximate cause, you're causing it for the moment, but you could be helpful to recognize that and get away from that. As far as cure, of course, we absolutely do not need you to cure TMD because it's simply not a cure. So for a patient to walk into your office and many times referred by a general dentist down the street, and they say, this patient has a malocclusion and TMD symptoms, I want you to treat them. What they really mean is, I want you to do orthodontics. But that's not what you're supposed to mean. Your job is to be an independent thinker. As one of my great oral surgery mentors, Dr. Laskin, used to say, I'm not a pharmacist. I don't fill a prescription. So if a guy down the street tells me to cut off the top of your condyle, I'm not going to do it just because he wrote it down on a piece of paper. So it's pretty important to have an independent brain while you're working. So what's the first intersection between you and the TMJ? And the first one is you have to understand growth and development in a way that goes way beyond anybody else in dentistry, including the pedodontists. The pedodontists don't even come close to understanding the level that you guys do about how important the TMJ is as part of the growth system. Now, is it a system in which the condyle is a growth center, as earlier proposed by Sarnat and Zischer, or is it Melvin Moss's functional matrix theory, which is much more complex and much more likely to be correct, by the way? It's pretty clear the condyle is simply not an ordinary growth center. It's just way too simple. And then we have also Dr. Don Enlow, who used to talk about bone modeling and remodeling and how the TMJ plays a part in that. Also, you have to realize that you're going to have some situations in which the abnormal TMJ situations are going to arise. You're going to have some internal derangements, and that will have some effect on mandibular symmetry. But is that important? And if it is important, how important is it? And do you need to react to that or not? We need to talk about that. And then on top of that, there's the problem of degenerative joint disease, and a particularly bad one called idiopathic condylar resorption, ICR. The human TMJ is one of the few joints in the body that's capable of such a massive resorption. One of the few other places is in the hip, and that's actually avascular necrosis, which is not the same disease. So the TMJ has a unique problem that it's capable of having, and it's idiopathic, which means we don't know why, and we don't know who's going to have it in advance. We don't have any predictors of who those patients are, although there's a few clues that certain types of morphology might be more susceptible, but we really don't know. So remember that you can be working along doing a perfectly fine job, and suddenly your patient becomes idiopathic condylar resorption patient. That's a bad day. And the way you're supposed to recognize that is you're supposed to notice that you're developing anterior open bite when you're not trying to, because that's because the condyle is resorbing. So intersection number 2 is you have to think about whether these things that your profession calls functional appliances, are they for real? If they are for real, what do they do? And how do you know? So let's start out with the question, is the mandible growing? If it is growing, is it growing in the right direction or not the right direction? And if not, are you going to be able to make an influence on that with some functional appliance, which usually is just another name for repositioning the mandible forward and hoping that somehow the back end of the mandible will end up moving backward and the TMJ will end up back in the fossa region. That's a lot to hope for. So is the TMJ remodeling because you're pulling forward? If it is remodeling, is it doing it because of you, or is it doing it because of Mother Nature? If it is remodeling, is it doing it successfully? And where does the condyle end up when you get done? It could end up that it's way down on the eminence because you pulled it way down on the eminence and it never goes back. And so then what? It's not in the fossa region. Is that a bad thing? Is that a good thing? Do you want the patient to live the rest of their life with their condyle several millimeters, and I mean several millimeters, many millimeters ahead of the usual place that condyles are? I doubt it. I don't think you want that. I don't think you think that's stable. It's not. Is the research that's been done on this topic satisfactory? Are you satisfied that the people who want you to do functional appliances have persuaded you that they have the research to back it? And do they know how to predict the outcome of the study of the questions that we're raising here? Well, I doubt it. So I suggest you look at it pretty carefully, because I think what you'll find is that if you're an orthodontist and you want to use a functional appliance, you better be prepared to do full orthodontics as well. That I don't like amateurs using functional appliances. I don't like pedodontists using functional appliances. I don't like GPs using functional appliances because they don't know how to finish if the case is not really going well. At least in your case, you have the intelligence and training to know that if the condyles are not ending up in a good place as you're doing this thing and you're really not growing the mandible, you're just moving it forward, that's not good, and you have to now have a second act and be able to get out. So the final question is it worth it? Do you really need functional appliances in order to conduct your business of being an orthodontist? I'm not pretending to give you the answers to all these questions. I'm just raising them for you to think about. Now, the third intersection is that you need to consider screening patients for TMD. But the danger of screening people is that you might find something. So one of the biggest problems we have, and this is true in all of dentistry, is that if you screen for anything, you better be prepared to figure out what it means when you screen for it. So let's say you're screening for periodontal pockets and you find a 5 millimeter pocket. Well, what does that mean? On who? Well, if it's an 85-year-old lady and she has 32 teeth and you find a 5 millimeter pocket, I wouldn't get too excited about it. But if it's a 21-year-old young person with inflammatory gingival disease and a 5 millimeter pocket, then I think it's worth thinking about. So in the orthodontic world, you're supposed to screen your patients for several things, and one of them is to screen for TMD, and we're going to talk about this in a little detail now. What should you do if you find so-called positive findings, and how will that imply for your treatment plan? Is it going to affect your treatment plan if you have a positive so-called finding? And if not, or if you think it does, it's important, and you don't like to treat TMDs, then who do you trust to find out some answers? And this is a very serious problem, because another big difficulty of screening things is that if you screen, you might then think about referring because you don't like to treat what you found. So let's say you find pockets and you don't like to treat pockets, you refer to a periodontist. Well, that's a pretty reliable relationship. But who do you send for TMJ problems, for TMDs? And the answer is you better be careful, because the guys in your community who are the most likely to be advertising heavily on Facebook and everywhere else how wonderful they are at TMJ problems, those are the guys you don't want to refer to. So who are you going to refer to? Or better yet, how about you? How about you being the person who actually takes care of the patient? I suggest that you consider trying to do that. So let me get to my next slide here. Just a moment here. Okay, here we go. Okay. So what is a pre-treatment exam for TM disorders? You are supposed to look for so-called symptoms and so-called signs. So let's talk about symptoms. Well, first one is that you might find a symptom of pain, but what kind of pain? What pain? Where? What? How often? What? When? Under what conditions is there pain? So you can't just walk up to somebody and say, "Do you ever have pain up here?" and point to their TMJ, because a lot of people will say yes. And if you think you're done, you're not done. You just began a process that takes another 10 questions to find out what it means, because you have to say, "Okay, tell me about the pain. Did you ever think about it before today, before I talked to you about it? What do you do when you have pain? What does it affect? What effect does it have on you? Does it cause you to have difficulty chewing and talking and doing anything else? How often do you have it? What do you do about it when you do have it? Do you have a method for taking care of your pain? Or is your pain something that happens once a month when you open too wide because you're eating a very large sandwich? Well, then I'm not impressed with your pain, because that's not an important pain. So you need to know what the word pain means for each person, whether it's meaningful pain or trivial pain. Now, how about clicking? Remember, you're asking them about clicking. You haven't examined them yet. So you're going to say, "Do you have a click? You ever hear a sound up there around your jaw?" And the patient might say, "Nope." And then later on you palpate and they say, and you feel it with your fingers, and then you say, "Oh, I feel a clicking here." And they'll say, "Oh, you mean that?" And they start talking to you about it. But a lot of times they'll say, "Oh yeah, I hear a click." Okay, now that you have a positive answer, you have 10 more questions to ask them. You have to, as the previous lecturer was talking about, what does clicking really mean? You have an anterior displaced disc if it makes a click, but what does it mean, and how are you going to deal with it, and how important is it, and how likely is it to be unimportant, and how likely is it to be resolving over time or improving over time? So the real question is, did you care about clicking before you met me today? because I'm meeting you for the first time today. I'm doing a screening. And I want to know whether you have observed yourself to have click, whether you've ever discussed it with your dentist, whether your dentist has ever given you. Sometimes they'll say, well, yeah, I told my dentist and he told me, oh, that's really bad. That's why I'm here today. And then they say, uh-oh, that's not a good thing. You really don't want a patient who was sent to you by a general dentist because they're clicking, because that means that you now need your intelligence to kick in and say, wait a minute, let's find out more about this clicking and see if the general dentist has overreacted to the positive answer. How about functional limitations? You see to somebody open your mouth and you see that they open up and it doesn't open very wide. So you say to them, I notice you didn't open your mouth very wide. Do you ever notice that? And they'll say, nope. That's the end of that discussion. You don't have to talk about that because a lot of people just don't open very wide. Remember, the normal range means normal range. And the normal range begins in the low 30s and goes up into the high 50s in terms of millimeters. So if somebody says, I used to open more widely, but now I've lately noticed I don't open as widely as I used to. Now they're telling you a story that might have significance because that may mean that something is happening within the TMJ complex, and that's worthy of discussion. So you have to phrase these things in such a way that you're not just getting a yes and a no. You have to know what the words mean when they answer you. And of course, finally, you have to say to them, did you ever really actually have a TMD diagnosis or treatment of any kind in the past? Now, when it comes to signs, this is where you now take your hands and you put your hands on people. And again, we're in a dangerous territory here because it's possible to find things with your hands that are really not important or that are important. So how about if you find some clicking? Is that important? Did the patient know? You know, if you say to them, I found some click here and you just told me 5 minutes ago you don't click, and they'll say, oh, I didn't know exactly what you meant, but yeah, I've had that for a long time. This doesn't bother me. Okay, end of discussion. That's the end of that. How about tenderness? Let's say you decide to push on the masseter and they say, ouch. Does that mean it's important? So you say to the patient, did you ever have pain there before I pushed on you? And they say, no. Okay, end of discussion. It's not a discovery. It's not a discovery to find tenderness because you're pushing on people. Sometimes that happens. How about jaw deviations? If they open funny instead of right down the middle, is that important? Is it significant? Does it prove that there's something wrong on one side so they have to deviate to the bad side? Or is that maybe normal for them? Remember, the normal range of human beings is to include perfect opening and some deviation openings. And then how about limited opening? You're going to measure with a measuring stick, say, and it comes out to be 33 millimeters. And now you say to the patient, I notice you're opening 33 millimeters, and we usually think 35 millimeters is the minimum good opening. What do you think? And the patient will say, well, I think I'm fine. You know, I don't have any problem unless you think I have a problem. Well, this is where you become a real doctor. And you're supposed to say, well, my opinion is if that's your opening and you've never had a problem before with that amount of opening, I don't have a treatment that's called opening. So I'm not going to bother you about it. I just wanted to know because it's part of what I need to know. Obviously, you write these things down as part of a record, partially for your personal records and partially for legal reasons to have a good record of everybody. So after the screening, what should you do about the minor positive responses and findings and the major positive responses and findings? And by the way, what's the threshold to cross over from minor to major? And the answer is, I don't know. I can't tell you what the threshold is. You have to decide in every single case what the threshold is. Some things are minor and some things are major. And you have to interpret it to the point where you would either decide this is acceptable variation of human beings or this represents a problem. And remember, a good rule that would be helpful to you is that TM disorders of clinical significance are not discovered by doctors examining them in a screening exam. Clinical important TM disorders are reported by human beings who are experiencing a bad thing happening to them. So don't think of TMD as this thing that you find the way you find pockets. You can't ask people if they have pockets, but you can ask people if they have these TMD phenomena. So I'm going to move on from that to the next point about this, which is what should you do with the minor TMDs? Should you send the patient to an expert for a thorough exam? And the answer is no, not necessary. Should you say, oh my God, I can't touch this patient until the expert tells me that it's okay? Oh no, don't do that. Because if you send the patient off to an expert, they're never going to say it's okay. They're going to say, this is not good. I'll send the patient back in 2 years when I'm done fixing their TMJ. So I suggest that you educate yourself to the point where you know how important it is or not important, and that you don't have to say, well, I can't even begin to touch you until you have a perfect TMJ, because that's not true. Your business won't be normal if you do that. Now, should you document everything and write it down and proceed ahead? Yes. Should you take normal cautions and precautions because maybe you're a little worried that they're a little vulnerable? Yes. Should you take some special cautions and precautions? Maybe. If, for example, you may be concerned about class 2 elastics or chin cups or something like that, because they might put forces into the system of a vulnerable person, and you might push them over the edge, and they'll become more significant. So you do have to use your brain here in order to do this. For the major TMDs, that's different. This is when they come in and they report TMD, either because they walk in the door or because they were referred by the dentist down the street. And the question is, should you delay orthodontic treatment until the TMD subsides or is gone? And the answer is yes, if you can. But if it's a chronic fluctuating temporomandibular disorder, you don't want to deny the possibility of having ortho. You can't say to somebody, I'm sorry, I can never treat you for orthodontic treatment because you have a jaw that isn't perfect. You have to say to them, listen, you have a jaw that is imperfect, and you explain to them what having temporomandibular disorder means, and you explain to them that the forces that you're going to be using may be a strain on the system, and that you're prepared to compromise. You're prepared to do a more minor treatment instead of a more major treatment. There's many different ways to approach this. You shouldn't deny therapy to people just because they have a history. But if they are acute and you can treat them, or somebody else can treat them until their symptomatic situation improves, that's the preferred route for the acute cases. You reemphasize that the major dentistry available in the world today, including orthodontics, will neither improve nor exacerbate TMD in a predictable way. You really don't know. But on the other hand, you can't promise that it won't. So you have to say, yes, you are at a more at-risk patient than my other patients that are seeing me today. And you have to be prepared to alter your treatment plan, and you may be prepared to make compromises of lesser forces and lesser procedures and quicker pathways to the end. And a final question is, who should treat the TMD? And I don't have the answer for you on that, except that you have to be very careful about the guy down the street who says that he's an expert. So you better be careful that if you have somebody that you really trust, good. If you don't, you better start learning enough yourself so that you can be primary care providers, because you can. I tried to teach my orthodontic students to be primary care providers for simple and non-complex TMD problems. Okay, moving to the next intersection, the TMD patients referred for ortho treatment. So the first thing you do is you say, okay, your dentist is a good guy and he cares about you, and he thinks that, that your malocclusion is causing you to have your TMD symptoms. But the truth is that we have a lot of research, and then you can quote a lot of the research. I have some of it here on the slide today, and tell them there is not a relationship. I am not going to provide orthodontic care for you as a treatment for your TMD. Now, there are many orthodontists who work exactly the opposite way. They think this is a great opportunity. Patient is referred for TMD. They immediately say, yep, you're in the right place. And they start doing all kinds of malocclusion treatments. I don't like that. I don't approve of that. I don't teach that, and I don't think that's good practice. Should you offer to treat the TMD? Yeah, using conservative treatment protocols. Or should you refer because you say, I really don't like to do any kind of TMD treatment, but I only like to do braces. Okay, now you got a problem. Who are you going to refer to? We're back to that problem again. Okay, intersection number 5. What do you say to a prospective ortho patient about so-called TMD risk factors? Well, there's people who claim that some of these things are risk factors, but in fact, none of them have been proven to be predictive for TMDs. So malocclusion, especially class 2, division 2, that used to be when I was at Northwestern, that was a big deal. They used to call that the trapped mandible. So if you had a deep bite class 2, division 2, that was a trapped mandible. So when I asked my students at Illinois, what do you guys do when you have a trapped mandible? They said, what's that? I never heard of it. Because we were only 3 miles apart from the 2 schools, but one school was doing that all day long and the other school never heard of it because it was entirely parochial. It applied to the teaching at one school, the teaching at the other school didn't cover it because it wasn't a real issue. What about skeletal disharmonies and open bites? Are they predictive of TMD? No. How about functional shifts, dual bites, cross bites? No. They're all things you care about. They're all things you want to manage, but they're not predictive for TMD. And again, you go back to these papers here of McNamara, Seligman and Okeson, and Michelodi and Iodici papers. These are classic papers that deal with all these questions. I'm not going to go through this, but I can tell you there's been a whole series of studies, starting with Sadowski and Bagol and moving on all the way through this whole bunch of studies. And if you notice in the final results column, there's no significant difference in post-orthodontic patients versus ordinary patients who never had orthodontics, even though they had the same malocclusions. So this is a very important series of studies to know about. And by the way, I don't know if Dr. Desmarais has told you this, but you will be getting a paper that has references for much of what we're talking about here today, and you'll be able to read about this whole concept that we're covering here today. So let's talk about number 6, intersection. What do you do in your own practice if your patient suddenly develops TMD? It's another reason why you can't avoid it. You're not allowed to avoid interest in TMD because it may happen to you. So now you have to react. How are you going to react? Are you going to just say, "Oh, don't worry about it. It'll go away when I get done. As soon as I get rid of all this hardware in your mouth, it's probably just because it's a strain, and we'll be done soon, and you'll be fine." You can't do that. You have to not blow off the complaint. You have to be prepared to seriously listen when they arise, when the symptoms arise, and determine if it's a major onset of an acute case. And then you have to deal with it. You have to document it in the record. You have to stop the active procedures. I'm speaking now about what you're doing, because you don't know which one of these 2 following things is true. Excuse me. The TMD may be coincidental, just related to the fact that you're treating adolescents, for example. Adolescents is the first group that TMDs begin to appear in. Or the TMDs may be a response to the forces that you're introducing into the system that they can't tolerate because they are vulnerable people, not normal people. And again, at the bottom, it says who should be treating. So treat or refer, how do you decide? Well, the definition of an expert in legal terms includes all of you. So you are allowed to treat TMD, even though there's a specialty of TMD, just as you're also allowed to treat periodontal disease, and you're allowed to do prosthetic dentistry, even though there are specialties of these things, because all dentists are specialists in dentistry, and TMD is part of dentistry. So yes, you can provide initial conservative therapy. And if you've been reading the literature on TMD, you know that acute cases have a tendency to get better. Chronic cases, of course, are different, and that's a different thing which we won't talk about today. The danger of referring to the so-called experts is that you don't know who they are, what's their training, what's their credentials, what are their concepts, and how will their treatment affect your treatment. So my advice to you is don't refer to anybody until you go to lunch with them. Sit down and tell them, listen, I'm an orthodontist. I sometimes have TMD things arise in my practice. I heard that you're interested in treating TMD patients. If I send you somebody, what are you going to do? What's your protocol for taking care of people? And listen carefully to what they tell you, because they will reveal themselves, I promise you. If they tell you, my concept is that I put a splint in their mouth for 2 years and then I move their jaw 6 inches further back, then don't go to lunch again, because you're done. That's enough lunch. So intersection number 7 is the great debate. Where should condyles be when you finish? And the answer is, depends on which one of these you want to believe. You should put it where the nathologists tell you to put it, or where the articulators say it ought to be, or a CPI instrument tells you where the right place is. How about the AAO guidelines? They tell you where to finish cases. How about happy muscles? You want muscles to be happy? Where should you put the condyles to make them happy? Or is it okay to do it anywhere and don't worry about it as long as you're not finishing in protrusive? And is there any evidence to support the best or ideal place? Why are orthodontists so worried about this question? The answer is they're worried because they're trained to be perfectionists. And that's one of the problems of being an orthodontist. You tend to be interested in perfection. I like that, but I don't like it when it gets crazy. So don't allow fear of imperfection to cause you to do more than you really should be doing for somebody. The fear of relapse is reasonable. Stability is crucial. You want to produce that, yes. You have to be careful to do that. You have to try to do that in all your cases, whether they have some TMD symptoms or not. You have to also be afraid sometimes, because your referring dentists will think you're a bad orthodontist because you won't accept their TMJ patients. Well, yeah, okay. How are you going to deal with that? Well, the answer is go to lunch with that guy. Go to lunch and sit down and talk and say, listen, the reason I don't accept your patients as a TMD patient and treat them orthodontically is for the following reasons. And then you read them all the stuff that we talked about today and explain to them that that's not the correct, reasonable approach for treating TMD. There's also a fear of so-called experts, not only outside of your profession, who are people like call themselves nathologists and other names like that, but even within your own field, you have authorities like, say, a Ronald Roth type of person who will say, the reason that many orthodontists don't get good results is because they don't do nathologic finishing on orthodontic cases. I'm sorry, that's just not correct. It turned out not to be correct. Roth's first paper was based on 7 patients, and it became famous. I still don't know why to this day, but here we are. And then, of course, there's always the fear of lawsuits. You're always worried that you're going to get sued by somebody. Well, life is full of fear, but it's also full of achievement and accomplishment. So try to accomplish things. So finally, I'm going to finish here now with my showing you a case that came out of Japan. And it was published in the American Journal of Orthodontics in 2008, just about the time I was writing this lecture, and actually the paper that this lecture is based upon in original form. So here is a fairly obviously young orthodontist, because he's a lecturer, not a professor in the Department of Orthodontics in Japan. And he's going to tell us about a surgical orthodontic treatment of a patient with a nathologic splint. So here's the patient. I want you to look at her face carefully and remember it. And look at the occlusion carefully and remember it for what it's going to look like later. So we have the standard photos to start. And the patient's complaint is occasional left TMJ noises, no pain. Recently, a more loud noise with some pain and some limited opening. Clinical diagnosis, the guy says she has lateral disc displacement with reduction. This was before there were MRIs. And he's diagnosing a lateral disc displacement, which is almost impossible to believe that you could say that. Then, of course, he makes an anterior repositioning splint, which the previous lecturer told you how that goes. And the symptoms, of course, varied up and down for 2 years. And she was offered a choice. Would you like to have prosthodontic or orthodontic finishing for your case now that I've made a splint and changed your bite completely? And the patient said, well, I think I'll try the orthodontic version. So let's go for that one. So she ends up in his department. So he has a CPI instrument that he uses, and he shows a small amount of condylar distraction. Condylar distraction means the condyle is moving away from the skull. That actually is anatomically impossible. Cannot happen. The condyle can never move away from the skull until you die. That's how much force there is in the system. You are living in a system that has constant vertical muscle force holding the condyle against the skull. Therefore, that is a completely ridiculous diagnosis. Also, he has MRIs that show bilateral anterior disc displacement with reduction. So he says the first thing you have to do is you have to stabilize the condylar position. Without condylar stability, how are we going to know what we need to do? Now just think about that sentence by itself. Without condylar stability, we don't know whether we need orthodontic treatment or what else we need. Think about that. So now here's the result of wearing a splint for 2 years. That's her occlusion. That's what he's going to do for us next. This is mounted in centric relation, by the way. So after 2 years and 11 months of splint therapy, he uses the CPI and he says, okay, I'm satisfied. I got 3 readings in a row on the CPI and they're all the same. So you're good. Your joint is now in a stable position. Of course, it's in a ridiculous position, but it's in a stable position. So now the pre-surgical orthodontic treatment is then carried out. And now they have 17 months of pre-surgical splint therapy to restabilize the joints while an anthologic splint is placed over the brackets. So imagine now you got a patient with a mouthful of brackets wearing a splint over the brackets in order to restabilize the joints, because while you're doing the orthodontics, you're unstabilizing the joints. Talk about going in circles. So here we are. Here's a nice looking young girl, the way she starts out. And of course, they managed to open her up about 12 inches there. That's nice. And so they got a long way to go. But nice thing about orthodontics, if you pull long enough and push hard enough, you get everybody back together again, right? So couldn't quite do it. They pushed and they pulled and they couldn't do it. So she said, you know what? Or the dentist said, you know what? I can't do it with orthodontics alone. I have to do surgery. Would you like to have double jaw surgery or one? The patient gets to vote, so the patient decided to go with one. Okay, so now they had orthodontic surgery on the mandible. Now tomograms are taken to see whether the condyle settled back into the right place. Got to be sure about that. And finally, 7.5 months later, he finally takes off the appliance of the orthodontic appliance. Says this is now a 63-month case. And look at her face, and look at her occlusion. It's almost the same as the pre, except that her face has been pushed further back because of all the retrusion and the mechanics of everything else that was done. I think you understand what you're looking at here. I won't go into details. So the question is, now he gets to write, because he's writing in the AJO, they allow him to write
Dr. Greene, sorry for interrupting. Could I please ask you to show the initial records?
I don't have any other initial records beside what I showed.
No, yeah. Could you please go back and just show the initial records? Because, yeah.
Okay, that's how she walked in the door.
Yeah, awesome. Mm-hmm.
Okay.
Let's see.
That's her walking in the door. And you see her face is a little bit more forward in the mid face down below. And then at the end, you saw what it looked like afterward. So now he gets to write a discussion section, because he's got this wonderful case. And I love it when people take one case and they think they can write a philosophy paper. So here's a philosophy paper. And he says the purposes of splint therapy is to know whether the joints will heal when they're rested by the full-time use of a splint with an ideal occlusion, meaning nathologic occlusion. that allows me to test the patient's response to future permanent occlusal correction. And since I'm an orthodontist, well, of course, we'll do it my way. If the joints fail to respond to this ideal occlusion that's provided, then occlusal correction won't be a viable therapy, and I'm going to have to send it to somebody else. But of course, it never comes out that way. Somehow, it always seems to come out that it'll be okay. I'm going to go ahead and treat you. He has more cliches for you. If mutually protected occlusion is optimal for normal joints, then we have to do that for the deranged joints. Well, first of all, the premise is wrong. Nobody ever proved that mutually protected occlusion is optimal for normal joints, let alone to say that every deranged joint has to end up that way. Some people will argue against the effectiveness of my treatment, but that's because of their technical inadequacy. Wow, talk about being arrogant. I'm good, you're not. I know how to make a good mutually protected occlusion if you give me 63 months and a whole lot of money. Now, how about to prevent the recurrence of TMD? There's no other methods other than surgical orthodontics or splints without orthodontic treatment. That's what we do. That's how the world works. So his personal conclusion is, my experience in treating many TMD patients who previously failed, of course he gets, everybody else's failures, is because they use conventional anterior repositioning splint therapy. And I don't do that. I use anaphylogtic splints. And of course, he makes it sound like there's some convention, which we don't have any conventions like that. He just made that up. So too bad for that. So this led our friend, this is a good friend, Don Rinchu, who's also Dr. Kandasami's good friend, who you'll be hearing next. He got so aggravated by this paper that he tried to write a letter to the editor. And he wrote, no scientific evidence that mutually protected occlusion is optimal. The same is true for canine protected occlusion, group function, or balanced occlusion. The same is true that if you have a mechanistic and rigid approach for addressing TMD problems by always putting the condyles in a certain place, that is not supported by research. So one must question this author's amount of time and the complexity of what he did to this girl. And the author writes back and says, well, you know what? Was that too long? I don't know. But for me, it was just the right amount. That's what the patient needed. That's what I did. And then he says, of course, when you don't have reproducibility, you can't have the right diagnosis. Well, that's a nonsense sentence. If you take that sentence and you convert it into Russian or English, I assure you, it will not make sense either way. And then he finally comes up with the ultimate thing that reveals that he's really more of a construction engineer than a dentist, because he says a building contractor must investigate the ground before planning the building. Otherwise, the building won't stand properly. That's lovely discussion for answering Don Rinchu's, but has nothing to do with all the points that Don Rinchu's raised in his letter. So what's my final advice to you? My final advice to you is stay with the J and drop the D. What do I mean by that? I mean by that you have legitimate concerns about the TMJ. You have concerns about growth and development, functional appliances, TMJ phenomena that occur that affect growth and development, and you have concerns about finishing cases in a reasonable and proper way. So you have to have a concern and knowledge about the TMJ. You don't need to have a primary role in TMDs. Your own literature generally supports this. And there's a reference down here to the AJO 1992. The complete issue of the AJO 1992 was on TMD and ortho relationships. If you ever can get a hold of a copy of that, ask Dr. Kandasamy about that. So in general, you do not have a role that the world needs for you to be the treaters of TMD with orthodontic therapy. But you could become part of our treatment team, and we would like that if you would do it reasonably and conservatively. And because your own patients may develop TMDs, you have to be involved. So when does a TMD patient need to have orthodontic treatment? And the answer is not absolutely never no. That's not the correct answer. The answer is rarely. Rarely, yes, and selected criteria. And so especially if we have a person who's had inappropriate phase 1 splint therapy outdated concepts of etiology, unproven technological concepts, massive occlusal changes. These are the risks for the orthodontist. This is why you don't want to get involved in doing these things the wrong way and being the person who creates these problems the way this guy did in Japan. He created a problem and it took him 63 months to get through the end of it by taking her apart and putting her back together again like some kind of a building set of some sort. So my final slide for you is that the great tragedy of science is when a beautiful hypothesis is slain by an ugly fact. So that's what tends to happen. That people have all these beautiful hypotheses and wonderful theories and claims of how wonderful how they are, and yet when it's checked by research and when it's challenged, you find out that it just wasn't true and people were making a mistake. So in the 21st century, we say reality bites. So I am concluding with that slide. I thank you. I'm going to stop the share on my screen here now and go back. Okay, and I'll go back to myself. And
So,
it should be on the screen now, yes?
yeah. Now we can see you. So Dr. Greene, thank you so much for this wonderful presentation. And it seems to me that the only thing which that this case is proving to us is that pretty much every case could be turned into a surgical case with a lot of work.
Well, let's just say that I picked that case because it's really especially terrible.
Yeah, exactly. That's what I'm trying to say. So, and I have to say that gnathology is extremely popular in our country and in Eastern Europe in general. And you know, we usually are seeing these patients coming to us with so-called gnathological splints, meaning splints which they have been wearing for many months prior to their coming to us. So I would like to know what's your experience at what point a reversible splint is turning to irreversible splint? At what point the changes of the bite are getting irreversible, like in terms of months, years? What's your experience on this?
Okay, I'll tell you what the really the really correct answer to that question is never. And the only reason I say that is because if you never make a splint that's capable of producing occlusal change, then you will never have a problem. So as you know from some of the papers I sent you, and you can distribute those to your colleagues, that if you make a splint to be a reversible appliance, if you make it to be worn part-time, if you make it with the goal of relaxing the muscles and taking a little load off the condyles and not changing the bite, that's your goal. Your goal is to never produce an occlusal change. And so I'm the exact opposite of the gnathologic splint people. I like the splints. I don't like the people who say splints are placebos. They're more than that. And I don't like the people who say splints are evil because they're only evil when you make them evil. So what I like is I like a conservative, reversible splint. My patients do not have bite changes when they wear splints. So the worst thing that should happen should be the failure to succeed with a reduction of symptoms. And then you say to the patient, I'm sorry, and I know it costs you some money to make a splint, but it's a reasonable therapy. We had to try it, just as they would in conservative medicine, try conservative care. And now, since that did not help you, we have to consider moving on to some further care for your TMJ problem.
Do we have any evidence to support the full-time wear of any splints?
No, there's absolutely no evidence for that at all. It's actually an invitation for disaster. If you say to somebody, wear a splint full time, you're saying to them, you are going to lose your occlusal program. You are not going to have MIP anymore. Your teeth will not fit together properly. And all you're really doing is you're setting them up for needing an occlusal change. So the people who do that, who force patients to wear splints 24 hours a day, are deliberately seeking to accomplish some phony goal that they have. Let's say their goal is get the jaw joint in the right place. That could be one goal. They might have another goal, which is to establish the right vertical dimension. Or they might have another goal of some other kind, get the muscles beautifully relaxed on an EMG. Whatever they claim, they're forcing the case into a phase 1, phase 2 operation. You do not want phase 1, phase 2. We don't do that. So every splint that I've ever made has produced no occlusal change. I have not ever had to deal with that in my own practice.
Right. And later today, we'll talk about your research paper on occluding versus non-occluding splints and the results of this landmark paper, because it was the first one where placebo splints were used, right? The first one ever.
Yes.
From early 1970s. Okay, so any questions from the audience to Dr. Greene?
Maybe what type of bite registration does Dr. Greene use? Is it?
What type of bite registration for making a splint?
Yes, yes.
I don't use a bite registration. I just hand articulate the models because almost everybody has models that fit together very nicely. And I'm producing a stabilization splint, or a so-called Michigan splint, that is flat. So I don't need to have any fancy bite registration. Now, if I have a patient with a complex bite, then I would do any kind of a bite registration that they're comfortable with, because I'm not looking to be in any particular place. I want to make sure they don't protrude. So I'm going to instruct them not to protrude. And I'm going to say, put your tongue back on the roof of your mouth, close your mouth into this rubber material, and hold still for 3 minutes. And that's it. I'm done.
So, and you have about what, 2 millimeters at your 2 millimeter distance vertically at your second molars?
And that's what I try for, yes.
Okay. Any more questions? So if we do not have questions, we'll be moving to our second guest today. So Dr. Greene, are you staying with us for some more time, because Sanjeevan is joining us now from Australia?
Yes, I am. It's one of my few chances to see my friend Sanj, and he promised me a really good lecture, so I'm going to stay.
Yeah, great. So as many of you know, both Charles Greene and Sanjeevan Kandasamy not long ago edited a wonderful book called TMD and Orthodontics, and it's even been translated to Russian, but I prefer to recommend it reading it in English anyway. So
today, I want to conclude by just thanking you again, Alex, for inviting me. And really, I appreciate the opportunity to address the audience. You all look like you're paying attention and learning a lot. You're young people. I was told that young orthodontists in Russia are shall we say, interested in learning and being in the right place at the right time. And you're there. So I think you're going to enjoy the next lecture from my friend, Dr. Kandasamy, and I appreciate this chance, and I wish you all well.
thank you so much, Dr. Greene.